Assalamu alaikum. I'm sure you must be wondering what these things say. I want to tell you what the last one says. If you don't leave in a minute's time, you'll be taken behind the hotel and shot. The topic I've been asked to speak on is chronic kidney disease, epidemiology and management. This is a massive and complicated talk, and this is the fourth talk, basic as possible. I'll try and keep it as basic as possible. Some slides are a bit complicated, but I'll simplify it. So, chronic kidney disease. So what is CKD, and why is it important? Chronic kidney disease is defined as some impairment of kidney function and structure that has been present for 3 months or more and is defined by a decline in kidney function, which we measure by GFR, or glomerular filtration rate, and or the amount of protein in the urine. Now, kidney dysfunction can be staged from G1 to G5, stage 1 to stage 5. Stage 1 is early kidney dysfunction. I won't go into the actual numbers, but basically it's a GFR above 90. End-stage kidney failure is a GFR under 15. This is end-stage renal failure. End-stage renal failure. And of course, there's stage 2, 3A, and 4. If you combine the amount of protein with the impairment of GFR, then you have a two-tier system. Now, here's the GFR, stage 1, 2, 3A, 3B, stage 4, and stage 5. The amount of protein is determined as either normal, where the amount is less than 30 milligrams a day, or microalbuminuria, where it's 30 to 300. And this you might not even pick up on a conventional dipsticks. It might be just a trace or 1+. And macroscopic proteinuria. What's important to note is that the darker blocks indicate the likelihood of progression of kidney dysfunction and or other complications. So the lower the GFR and the higher the proteinuria, the more likely is a patient to have some form of complications. It's important to note here that even microalbuminuria confers a higher risk of potential future problems. Thanks. So how common is CKD? How common is CKD? Thanks very much. That's perfect, yeah. These are two studies published in 2019 and 2020, one in the Kidney International, one in Lancet. In 2017, the prevalence or the number of patients worldwide was more than 850 million, substantial number, 10.4% prevalence in men, 11.8% in women. 843 million were not on dialysis, and the others were. So the total number is just above 860. I'm not going to go through every figure here. 860 million. So in 2017, substantial number of patients had CKD. A similar study published in 2020 in The Lancet revealed a prevalence of 9.1%, and this can vary considerably in different countries, going up to about 16% in some countries, as I will show you. But what you can see very clearly is that it's common. It is common. Important slide. This is the figure I mentioned, 843 patients with CKD not on dialysis in 2017. And that's 1 in 10. 1 in 10 people 1 in 10 people in the population have some form of CKD. So in this audience here, 1 in 10 of you have some form of CKD. But 80% of you are not aware of it. And this is the problem we're having globally. CKD is commoner in women, elderly, patients with hypertension, diabetes, and racial minorities. This is an extremely important slide in the middle here. This is the death, the commonest cause of death globally. In 2013, that's just 9 years ago, CKD was the 19th commonest cause of death. In 2016, it was the 13th commonest cause of death. In 2017, it was the 12th commonest cause of death. In 2040, it's estimated that CKD will be the 5th commonest cause of death. So this is what we have facing us in the next decade and a half. The increase as the cause of death from 1990 to 2017 is a 41% increase in the death rate. So CKD is becoming a common cause of death and will be worse as time goes on. If you look at Africa, the prevalence is overall higher than global figures. In Central and East Africa, you're looking at a prevalence rate of 14 to 16%. In West Africa, it's as high as 19%. Southern Africa, we're around 10.4, 10%. Oddly enough, North Africa has a low prevalence of just 6%. Important to realize as well that the prevalence of CKD increases with age. In the general population, 8 to 10%. People above 60, you're looking at a prevalence of 20%. And people over 70, you're looking at a prevalence of 35%. So 1 in 3 patients over 70 have some form of CKD, most often not yet diagnosed. Right, this slide shows the normal decline in kidney function with age. This is men, this is women. And you note that in both men and women, from about the age of 55, there's a slow decline in kidney function, reaching GFR of about 60 in men after about 20 years. And for women, it's a similar type of decline, slow decline. So that is why the elderly is always listed as a risk factor for some form of CKD, especially if there's an added insult like blood pressure, obesity, hypertension, etc. This is another important slide. Can I just hold this? Yeah. It's fine. This is much better, yeah. This slide shows the number of patients globally who are on dialysis or have had a transplant, or have a transplant, showing from different parts of the world. That's 210, this is 230. And as you can see that the numbers, this is now stage 5, this is stage 5 kidney disease, it's expected to increase globally in developing and developed countries. In Asia, that's an increase of, that's 20 years. The US, similar increase, that's about 100%. In Africa, the line actually looks to be flattish, but actually the increase from 210 to 230 is 300%. And we are just 8 years away from 2030. So for Africa, that's an astronomical increase in the number, that's end stage now, not early, this is end stage CKD. The increase in the number from 2020 to 2030, that's 3.8 million to 5.4 million, represents an increase of 42%. So that's a 10-year increase from 2020 to 2030. And I'm talking now about end-stage kidney disease requiring a transplant or some form of dialysis. Right, this slide shows the number of patients with end-stage kidney failure who are treated relative to countries' GDP per capita. On the left, these are the rich countries with a high GDP, and as you can see that far more patients are treated than in sub-Saharan Africa. If you look at Japan, Taiwan, now these are the number of patients per million of the population who are treated with dialysis or transplant. And you can see that Taiwan is treating about 3,000, Japan 2.5, US 2,200 per million of the population. If you look at Africa, South Africa is treating just around 180 to 190 patients per million with dialysis or transplant. So we are treating about 1/10 the number that the developed countries are treating. Right, there's a lot on the slide, but basically we're looking at what causes CKD and the risk factors. One needs to really, the slides are on the website, so you can go through this in detail later on. But basically we are interested in diabetes, hypertension, age above 60, a non-white race, and the ApoL1 gene. The ApoL1 gene is found in sub-Saharan Africa and in African Americans. There are certain other conditions you need to bear in mind. Analgesic abuse, toxins, kidney stone disease, obstruction, malignancy, certain types of drug abuse, smoking. I see this slide hasn't got a high protein diet, but that is listed as well. In particular, the combination of obesity and a high protein diet, which is found in the US. We won't go through everything in detail there. Right, this is also an extremely important slide. The previous slide showed so many causes of kidney failure, chronic kidney disease, but 80% of CKD is caused by diabetes, hypertension, and obesity. And many of you will be seeing patients now who are becoming diabetic at a younger age and having complications at a young age, starting dialysis at a young age, having laser therapy for an eye problem at a much, much younger age. And this is a global problem. So these are the conditions we need to be looking at in terms of picking up early. And in that way, if we can diagnose CKD in stage 1 or 2 or 3A, there's something you can do to slow the decline and lower the rate of complications. Or even perhaps, best guess is to stop these patients developing even stage 1 CKD. But these patients have to be screened. They have to be screened. The low prevalence of screening is not only a problem of developing countries, it's a common problem in the developed world as well, where this group of patients are not adequately screened, and we are all guilty of this. I mean, how many of you would say, well, this patient's obese, I think we should do some kidney screening here? You would never think of it if you get somebody who is not diabetic or hypertensive, but just obese. You're not going to screen. People don't screen. But this is the cause of 10% of CKD. These are some of the rarer causes of CKD. I won't go through it in great detail. Certain herbs used in Africa and Asia and in the agricultural field, certain Chinese herbs used in slimming treatments in Belgium and the Balkan area, heavy metal contamination of water in Sri Lanka and Indian farmers. The actual contaminant is not determined. In Central America, there's an unidentified toxin with sugarcane farmers in El Salvador. But these are rare causes, and one should think of it if you are working in that area or you come across somebody who's been exposed. This is just another slide that shows you the brown coloration is diabetic causes of end-stage renal failure. This is the US. The red is hypertension. So the combination of diabetes and hypertension causes about 80%, this is the US, of end-stage chronic renal disease. 80%. So why is CKD at all levels a problem? Why do we need to even worry about it? The first problem with CKD at all stages, even stage 1, is an enhanced cardiovascular morbidity and mortality. This is stage 1 to stage 5, and this can be 8 to 10 times higher. The lower the GFR, the higher the complication rate. This 8 to 10% can be higher in some studies. In the US, this can be as high as 15 times, which means the cardiovascular morbidity and mortality compared to a normal patient is 15 times higher. That's an astronomical difference. The other complications is a risk of progression to end-stage renal failure. Then, of course, in early CKD, pre-end stage, there are a few complications, mainly diabetes, anemia, and mineral bone disease. And we'll discuss management of that briefly. So, sorry, this is just talking about the cardiovascular and other complications at different levels of GFR and levels of proteinuria. And basically, you can see all-cause mortality, cardiovascular mortality, end-stage kidney disease, acute renal injury, progressive CKD. The lower the GFR and the higher all-cause mortality, the higher the risk of that particular complication. So our aim is to really to keep patients early in stage 1 or stage 2 or maximum stage 3A. As I've mentioned already, the presence of microalbuminuria confers a significantly higher risk in all the complication rates. So even microalbuminuria has to be controlled. I'll have to really speed up now. This again just shows you the similar data, but what I wanted to highlight was that the red section is high proteinuria, green is micro, and the GFR is on the horizontal axis. And once GFR goes below 60, all complications suddenly increase dramatically. That's all that slide is meant to show. So, same data really. So who should we screen? It's impossible to screen the entire population, not cost effective. So one has to target patients who are diabetic, hypertensive, obese, cardiovascular disease, family history, CKD, HIV infection in Africa, and perhaps African Americans. So this population has to be screened so that we can pick up patients who don't even have CKD yet, or who have early CKD. So why do we want to do that? The basic screening test is blood test and a urine test to measure GFR, creatinine, amount of protein, sometimes imaging studies. And this should be done at point of care, which means that you have the results immediately. Now, in terms of prevention of CKD, there are 3 stages. Primary is before the patient even have CKD. That means diagnosing diabetes, hypertension, whatever, SLA, whatever, early on, controlling it so there's no renal complication. That's primary prevention. That's primary prevention. Secondary prevention is, there are 2 stages, early CKD, late CKD. With stage 1 and 2, and perhaps even stage 3A, with good management of diabetes, hypertension, weight, etc., you can delay or even stop progression of CKD. Stage 3 and 4, you're going to need much more attention to managing complications of CKD and preparing the patient for possible dialysis and/or transplantation. I'm just going to, the slides are all, will be on the website. If a patient already has CKD, this will be one more slide after this. If the patient already has CKD, basically you want to control the underlying disease, whatever it is, diabetes, hypertension, obesity, vasculitis, whatever. That has to be important. Then to prevent any further damage, so you control the underlying problem, then to retard and to protect whatever kidney functions left, you need adequate blood pressure control, diminished proteinuria. There are several drugs can be used. I won't even talk about SGLT2 inhibitor, that's a new drug. Any other nephrotoxic event needs to be avoided. Anemia needs to be managed, renal bone disease needs to be managed, and patients, if they progress, needs to be prepared for renal replacement therapy. I'll go to the last slide. We'll leave that out for now. So, diabetes, hypertension, obesity are major problems, major cause of, 80% cause of some form of CKD, early to late. We need to screen this population, and ideally, we want to pick up CKD, stage 1, stage 2, perhaps stage 3A. Governments need to be informed via registries about numbers of patients so they can make informed decisions about future care. And we need to screen. We need to screen the high-risk patients. Thank you. I'll have to stop there.